So, hello everyone. This is Grant Marksoff. I am the professor in the School of Nursing here, and this is the kickoff to the Spring Research Colloquium for the Nursing, Health Services, and Policy Research Hub at the School of Nursing here at the University of Pittsburgh. So, I'm the director of the hub and have historically run this colloquium, but I'm Andrew Dierkes, who I'm going to introduce in just a minute, has graciously agreed as one of his first acts as an assistant professor in the School of Nursing to take over this colloquium. So mostly because I think he's going to do a great job, but also I teach on Tuesday and Thursday mornings, so I'm going to be missing the second half of these most of the time. So going forward, Andrew will be recruiting people to participate in the colloquium. If you're interested, please email Andrew, and Amy Comedina has been helping Andrew, they're helping me arrange these, and then we'll be helping Andrew going forward. So I'm going to be introducing Andrew, and I'll jump off in a few minutes because my class starts in about 10 minutes. So again, help me welcome Andrew Dierkes. He is a brand new assistant professor here in the School of Nursing. He is a registered nurse and health services researcher. He, as a Hillman Scholar in Nursing Innovation, he completed his undergraduate and predoctoral training at University of Pennsylvania through an integrated BSN and PhD program. He also did postdoctoral training in the Center for Health Outcomes and Policy Research, which also at the University of Pennsylvania School of Nursing, which is really the epicenter of health services, nursing health services research in the United States, with Dr. Linda Aiken, who really founded this field for all intents and purposes. So Andrew is very well trained. We're really excited to have him here. He has a number of interests, particularly nursing workforce, issues around staffing and sepsis. And so I think that he'll find a lot of people here in the nursing school and also in the medical school who have some interest. And I think the purpose today is really just to introduce Andrew to you, give him an opportunity to tell a little bit about the work he's interested in, maybe make some connections. And then we're really looking forward to helping Andrew get going. This is obviously a very difficult time to start a new job as a tenure track professor. So we're going to do the best we can to help him get situated, and I hope that this is one early step to help him move along. So thanks, Andrew.
Thanks, Grant, for that introduction. I really appreciate it, and thank you to everyone who's tuning in today. I appreciate your support, and this is a great way to introduce myself to you. I will share a bit today, just briefly about kind of my personal background, and then jump into my research trajectory that brought me here to Pitt, and then some plans for the near future and far future, hopefully, in research at Pitt. So let me see if I can share my screen with you, and I have some slides to share. Okay, I hope that you can see my slides here. So the topic that I'd like to discuss with you today is about leveraging healthcare's largest workforce, that is nurses, and focusing on improved care delivery and outcomes. As Grant mentioned, this covers a lot of my interests, which are somewhat broad, and I'll give some examples of some research I've done and research I am planning to do that falls under this kind of broad theme. Let's see if I can advance. There it is. So just a brief overview of what I'll share with you today. I'd like to introduce myself, both personally and professionally. As Grant mentioned, it's a bit odd to be starting this job during these times of social distancing and quarantine and remote work. So I thought maybe some of the stuff you would learn about me if you bumped into me in the hallway or got a cup of coffee with me at the School of Nursing, which I do hope we can do. This isn't to replace that, hopefully someday in the near future. But I thought I'd give a little personal introduction and then jump into my research trajectory, bringing you up to date to how I came to be at the University of Pittsburgh. I'll do that in part by way of just a brief overview of two studies. Some of you may have heard of some of these studies, so I'll keep them brief and then leave time for discussion at the end. If you'd like to follow up with questions on either of them, happy to do that. And then share a bit about some current work, specifically a grant that I'm just beginning to work on here at the university. And then, as I mentioned, leave plenty of time at the end for discussion, hopefully learn a bit about you, and then address any questions you may have. about content of the presentation. So just kind of a brief personal introduction, nothing, there's kind of no rhyme or reason to these, but just to share some different aspects of my life. I grew up in a big musical family, and I still play a lot of music. I play the piano and the violin, and I happen to have the opportunity to play the pipe organ quite a bit, mostly in a liturgical setting. But one of the things that I really enjoyed that was non-academic during my years at Penn was pictured here in the left part of the screen. Is Penn happens to have one of the largest pipe organs in the world in its Irvine Auditorium. And there were a number of times where I had the real pleasure of taking students, but also visiting conferences or individuals who just kind of as a novelty would visit the instrument, and I would kind of play a demonstration of the instrument for them, and they would get a tour of the pipe chambers and whatnot. So that was kind of a fun, odd, but really rewarding experience, non-academic experience at Penn. I do enjoy being outdoors. This past summer, I had the great opportunity with some of my siblings and other friends to hike the Presidential Traverse in New Hampshire. So that was an all-day experience. We started before the sun got up and finished hiking with headlamps, finishing up at around, actually it was quite late, but we got all the peaks done in just a day. So kind of a fun, bit of an extreme experience. And then as Grant mentioned, of course, I did my research training in a school of nursing, but I am also a practicing registered nurse. I worked at Pennsylvania Hospital up until the beginning of this month when I started at Pitt, and had been on the same unit for a number of years. And so I included a picture of my preceptor who still works on that unit. And I worked alongside her for a number of years and actually published some research, which I'll briefly mention a little bit later, with her. So I was able to really integrate my research interests with my clinical interests. And that's been an important part of my professional research trajectory, really grounding my experience with research, with the clinical experience, and vice versa. So briefly, I'd just like to include a little bit of a timeline of more professional research-oriented timeline or milestones. Grant mentioned that I did all my training at Penn through an integrated program called the Hillman Scholars in Nursing Innovation Program that was an integrated BSN to PhD. And whoops, I think I lost my screen there. Let me get that back up. There it is. And even stayed at Penn for my postdoctoral training in the Center for Health Outcomes and Policy Research with Dr. Linda Aiken and Dr. Matthew McHugh as my mentors. During this time, and as soon as I got my RN license, I started my clinical practice at Pennsylvania Hospital, and so had this clinical grounding to all this research, which I mentioned was really influential, and I really valued it. And then as a third kind of category or trajectory, I was pursuing different forms of innovation and implementation training. I went through the NSF I-Corps program to travel around and speak to people in hospitals about issues with staffing, scheduling, and assigning, and I'll share more about that kind of work and what stage that is in today later. And then finally, as of the beginning of this month, I'm very pleased to now arrive at the School of Nursing, and specifically in the Department of Acute and Tertiary Care at the University of Pittsburgh. So my research trajectory is really grounded in and influenced by Dr. Linda Aiken and my training at the Center for Health Outcomes and Policy Research. And just to give you a background so you understand where I'm coming from, a lot of the research that comes out of that department is grounded in this model, which says that interventions, the things that, for example, nurses do not directly impact the outcomes of a patient, but are instead mediated or moderated through the system context and individual patient characteristics. So a bit of maybe a simplistic understanding of this, but I think an example of what this looks like at CHOPR, the Center for Health Outcomes and Policy Research, is looking at different nursing characteristics, things like staffing or the composition of baccalaureate educated nurses in a hospital or the hospital work environment. Those are system level contexts that we can modify. And by modifying those things, that we therefore impact the effectiveness of those interventions in terms of achieving patient outcomes. And so much of the information that we have examined over the years comes from the RN forecast, which is this large survey of nurses in 4 states primarily, although that's changing in future iterations of the survey, which is exciting. And it's a direct-to-nurse survey. The survey asks nurses questions such as how many patients did they care for on the last shift, and they report as well the hospital or setting in which they practice. And combining that information, we're able to aggregate those results to the hospital level, merge in some other information from, for example, the AHA annual survey of hospitals, and as well as patient discharge information or claims data to get outcomes and different information on the patients cared for in those hospitals. And as a result, to begin to develop models that explore the impact of things like staffing, education, and work environments on patient outcomes. So some of the earliest papers that I had really the pleasure of working on, and where some of my training came from just very early on, looked at things like nurse engagement and nurse staffing, or shared governance in hospitals and patient and nurse outcomes. And in fact, I love highlighting this paper on the right here about nurse engagement, because when I was a pre-doc at CHOPR, Haley Germack, who is a faculty member at Pitt, I'm sure many of you know, was really in the driver's seat for a lot of this paper and taught me so much about the process of data analysis, interpretation, and writing up of results. So that was a really formative paper, and I'm grateful to Haley for that experience. And then the preceptor who I pictured on an earlier slide is Patricia McGuire, who's also an author on this paper. And so I really had a great and very close knitting, if you will, of the clinical and research experience while I was at CHOPR, and that was very formative. So Grant had mentioned some interest I have in post-surgical sepsis, and I won't go into too much depth on this particular article. This is the subject of my dissertation, but I did want to mention it, so I'll just share a few slides about what we did and the findings. So I know I'm preaching to the choir for some of you on this presentation here, but what drew me to sepsis was that I really felt like it mattered. It's very common. It's often a deadly condition for patients, and it ends up being very costly as well. And so that intersection of attributes really attracted my attention as something that really mattered. And so I felt like there was it gave me a lot of energy to study this, and I thought it was enough to carry me through the dissertation, and it did. And then finally, this last piece, which made it so important for someone in a school of nursing, was that I really felt that nurses were so key to sepsis protocol success. It seemed to me that there was so much research and information on what we ought to do. We knew that we had to recognize sepsis early, and we knew that we had to respond to it quickly. And that if we could do those two things, patients had a much better chance of surviving sepsis. When I look at those items though, early recognition and rapid response, I think, gosh, nurses are so integral to that process that without nurses who are providing this 24/7 patient surveillance and passing that along perhaps to the medical team, And then likewise, the medical team might be passing down recommendations such as antibiotics or fluid resuscitation, vasoactive medications in response to that recognition of sepsis. But ultimately, those interventions often reach the patient through a nurse. And so nurses are there first to recognize and then the first to intervene. And so it really struck me that nurses were just so essential to both of these processes. They had to impact patient outcomes with respect to sepsis. So I examined surgical patients specifically, and we had some really exciting findings. We examined the sort of classic components that the Center for Health Outcomes and Policy Research likes to examine. We looked at work environments and found that better work environments had all the hospitals in our study improved their work environments to match those that were among the best we saw in our study, that it's likely we could have reduced sepsis cases by 5%, and that represented over 1,000 cases. And likewise, education seemed to have an impact on septic death. And so using the Institute of Medicine's 80% BSN benchmark, we were able to estimate that had all the hospitals in that study achieved that 80% benchmark, there would have been 804 fewer deaths, or a 13% reduction in septic deaths. And this was about a sample that represented about 10% of US hospitals and among surgical patients alone. So really believe that there's quite a bit of substantial improvements that could be made through these different types of system level interventions, through work environment modifications and through advancing nursing education. So just as a way of highlighting the breadth of my interests and something, this is a little bit more on the policy side and a more recent study, it's actually under, I'd like to share some work that I did in collaboration with others at Chopper, examining the impact of California's staffing mandate, specifically in the context of the economic recession on registered nurse staffing levels. Just a brief bit of background to help you understand why this was of interest. The Great Recession began towards the end of 2007 and lasted through mid-2009. And as of October 2009, there was significant unemployment. And this general period was marked by reduced healthcare spending and reduced capital investments. So the question was, in the context of the California staffing mandate, which mandates RN to patient ratios, and there isn't one strict ratio for all settings, it depends on the setting. So for example, in the OR or trauma patients in the ED, it might be 1-to-1, but on psychiatric units, they might allow up to 6 patients per nurse. And some of the implementation was actually phased in. So for example, on med-surg units, it was initially implemented as a 6-to-1, and I think it reduced down to 5-to-1, something like that. Anyhow, the cost of implementing these new mandates to be in full compliance with the state law was estimated to be about $700,000 to $800,000 per hospital. So this is happening in the context of this Great Recession, a time when hospitals are under a lot of financial stress. There's this cost of implementation. And so we were asking the question whether this state staffing mandate might help California hospitals protect their staffing levels, something that we know is important to patient outcomes, and how that might compare to hospitals in other states where this staffing mandate is not present. So California is the only state with a staffing mandate like this. So briefly, the overview here is we looked at the AHA annual survey of hospitals. We were able to generate from that data a hospital staffing measure of hours per patient day. We're comparing California to other states. We're looking pre and post the California state mandate and before, during, and after the 2008 economic recession. So it's a longitudinal study. We have data from 97 to 2016. We examined using fixed effects regressions, and we also included analyses that included entropy balancing, which is essentially a weighting scheme to help adjust for differences, baseline differences in hospital characteristics between hospitals in California and hospitals in other states. I'll show you what that looks like, or the impact of that approach in the next slides. So here we have that longitudinal trend for California hospitals in red and other states in the dotted blue line. And the general trend is upward over time. You do see, however, at the beginning of the recession, and perhaps even during this post-mandate, you can recognize it here a bit, where California staffing levels begin to increase at a slightly higher rate than do other states. And it's really in the recession where you see this drop off in staffing levels among other states versus California, which appears to have maintained and then improved its staffing levels following the recession. So whereas other states actually fell backwards in terms of their progress towards improving staffing ratios during the recession, California was able to maintain its staffing levels and then resume its growth following the resolution of the recession. And even by 2016, other states are just barely exceeding their pre-recession staffing levels, whereas California was able to really kind of take off and only widen that gap. Now here I promised to show you the effect of that entropy balancing. And we looked at balancing based on characteristics in that post-mandate but pre-recession period. And so what ends up happening is you constrain those staffing levels to be, they actually end up overlapping visually, which is kind of a neat visual effect of that entropy balancing. And you see that divergence in the post-recession period, especially, of the two staffing levels more dramatically in this image. So what did those actual differences in terms of hours per patient day end up looking like? Well, by the end of the post-recession period, or over that post-recession period, for California hospitals versus other hospitals in other states, it ends up being about an hour's difference per patient, which, if you're a nurse and you're working at the bedside and you think about an extra hour per patient per day, so that's not per shift, but per day, it's a significant amount of time. And I know just from my own experience, that's always time I would be asking for when I'm working with patients. And I can really understand how that would impact the care I can provide and at least the attention I can provide to a patient in the hospital. Okay, so I'd like to pivot a little bit to thinking about how more recently my thoughts coming into the University of Pittsburgh and approaching future work has been shaped. And one of those influential items, or something I've been looking at to think about, okay, how do I structure my approach to the coming years of research, is I've looked to this Bozeman meeting, which has outlined 5 challenges for the near future of health services and policy research. And these fall around the areas of behavioral health, primary healthcare, maternal healthcare, aging population, and then finally, value of nurses' contributions. And if I had to put myself in any one category, although I find opportunities, I think, where these overlap, but to choose one area, I would say my interests primarily lie in this 5th category, where we examine the value of nurses' contributions to health or healthcare delivery. And I'll give you an example of what that looks like. So I know I'm preaching to the choir here, but just to kind of get you on board with my thought process here, when I think about nurses, I am struck by the fact that they are the largest healthcare profession. that they are present throughout the in and outpatient care continua, and that when you think about yourself as just an ordinary human being here, odds are you've already received nursing care, and virtually everyone in society will receive nursing care at some point and at various points throughout their life. So it really does seem to impact everyone. And then narrowing that a little bit to think about nurses in hospitals. As I mentioned earlier, they're at the bedside in all hospitals, providing round-the-clock care. And this impacts annually over 30 million patients who are hospitalized who go through our hospitals. And we know from the work at Chopper and among others that the organization of nurses in hospitals impacts outcomes. And this impacts outcomes for patients. It could be nurses, the providers themselves, and nursing administrators, so hospital business outcomes, if you will. So just kind of a brief overview. I mean, this is by no means a comprehensive review of the literature, but just to kind of highlight a few different points here in recent articles. We know that things like staffing impact patient outcomes such as falls or satisfaction, measured through HCAHPS scores, for example. Or for nurses, it might be burnout, but maybe job satisfaction as well. And then finally, administrators are impacted by things like nurse turnover. It can be very costly for them, or pay for performance measures, also very costly. And then these outcomes also impact each other. So for example, the HCAHPS scores I mentioned under patient satisfaction, well, that impacts pay for performance outcomes. And nurse burnout ultimately is an antecedent perhaps to nurse turnover. So there are negative outcomes and then negative sequelae from the ways that we structure poorly or not nursing workforces, specifically in hospitals, but really anywhere care is provided. So when I think about nursing workforce management, I'm struck that there's no evidence base, or at least very little evidence base or consistent standard for doing things such as staffing, scheduling, and assigning. And these, to me, are the basic day-to-day processes in which we structure this care. And we know that they ultimately impact outcomes, as I mentioned, for patients, nurses, for hospitals. So these processes are happening every day in hospitals without clear guidance or a consistent approach. And just one example from little anecdotal evidence, where I worked at Pennsylvania Hospital, assignments would be made, these nurse patient assignments every day, every shift, and they're done with pencil and paper, you know, so it's a very kind of, it's not a very systematic process. It's given to the opinion, and now it's a professional opinion, it's based on experience of the charge nurse, but it depends on the charge nurse. You would get a different assignment if a different charge nurse was making that assignment, even given the same patients and nurses on that given shift. Now, coming from Chopper, my lens is mostly at the hospital level at this point. So the research that has been done is usually aggregated to the hospital level, looking at nursing resources, things like staffing. And therefore, the recommendations are also system level. So they might be things like pursue magnet recognition, perhaps to improve the work environment, or hire with a preference for BSN educated nurses, or just hire additional nurses to reduce that patient to nurse ratio. And while I appreciate those policy interventions, and I think I will continue working in that space, it seems to me that we need complementary evidence to begin informing some of these day-to-day practices at the individual level. And so that's some of the work that I would like to be doing, specifically looking at staffing, scheduling, and assigning, which are interrelated concepts. To simplify them and just to generally define some terms, I think of staffing as just number of nurses. How many nurses do we have in the hospital on a unit on any given shift? Scheduling, I think about problems as we have this pool of nurses who are employed at the hospital. How do we divide them across shifts given their individual characteristics so that, for example, we don't have all the inexperienced nurses on one shift and all the experienced nurses on another shift? What should that mix look like across shifts? And then assigning is, now that we have our pool of nurses on a given unit on a given shift, how do we begin pairing these or matching these with the given patients we have? And can we do it in a way that is outcomes driven? We're thinking about the outcome in mind, not just for patients, but also for nurses, and then ultimately as well for hospitals. And these concepts apply as well for other staff members. And it's important, I think, to keep those in mind, such as nursing assistants who work alongside these nurses and depending on the hospital, have different scopes of practice or responsibilities. So the current work that I'm going to describe a bit further, the central premise here is that if we can better align hospital nursing with patient needs and do that through more evidence-based staffing, scheduling, and assigning, that we can better align patient needs and preferences to leverage the nursing workforce to improve a wide range of outcomes. And so I've recently been funded by the Rita and Alex Hillman Foundation through their Emergent Innovation Program, and their call for proposals said, we see creative early stage, they wanted untested or minimal evidence innovations that address health and healthcare problems in new ways. And so what we propose to them is to say, let's develop a software platform that, at least in my hospital, where these processes are being accomplished with pencil and paper, that will help these nurses do this staffing, scheduling, and assigning, at least in a systematic way. And that this will also be a research instrument as well as a clinical intervention. So the concept here is that by developing a platform for these processes to take place, we can be collecting a unique data set, information on nurses, on patients, on those pairings, and that we can then use that data set to develop evidence. And then that platform is not only generating evidence through the program of research it's supporting, but it then becomes a platform that we can use to implement our findings. So, and this is looking down the road, this is kind of a broad vision, as some of this is outside the scope of the immediate grant, but just to kind of share this vision with you. So if you can imagine, you have a platform, these processes are taking place, we have a record of what happened and who is paired with who, for example, in an assignment, and then associated outcomes. We can do that research, perhaps generate some decision support, integrate that back into the platform, and then the cycle continues where you're able to evaluate those results. More specifically, the aims of this grant are to develop and pilot the software, to evaluate user satisfaction and perceptions of efficiency and safety. So pretty low-level evaluations, just to basically a feasibility study and to make sure things are at least better and not worse than older processes. And then separately, we'd like to model the impact of nurse-patient assignments on patient outcomes. So including characteristics of the nurse, of the patient, of the hospital, and then looking at the outcomes of those specific pairings. So this is drilling down to that individual level. To explain a bit more about these different aims, the aim to develop and pilot the software, as I mentioned, is really about demonstrating feasibility, really just making the current process electronic, perhaps gaining some of those lower hanging fruit benefits of making this more systematic, hopefully streamlining the process, making it less prone to errors, human errors that are associated with pencil and paper methods. And then I mentioned collecting that unique data set to support a broader program of research. The evaluation will be pretty basic, just looking pre and post implementation for nurses reporting the time they're spending making and updating assignments. Those nurses who are receiving assignments, do they feel that they're safer and or more balanced? And then just satisfaction. Is there greater satisfaction making and receiving assignments when you're doing it electronically versus sort of the older school method, pencil and paper? And then the last aim about modeling the impact of these assignments, I'd like to develop a statistical model using these various characteristics to explain harmful variation in patient outcomes, so adverse events. And the foundation is especially interested in vulnerable populations. And so we're going to examine whether patients' race, we're going to look at interactions with patients' race to examine whether racial minorities have more to gain from assignments that are better aligned with their needs and preferences than perhaps any other patient. And what we would like to do once that model is developed is evaluate historical assignments and alternative nurse-patient matches. So if you can imagine that we have a data set, we've modeled the outcomes, patient outcomes related to the characteristics of assignments that were made, and then use that model to essentially, in retrospect, reorganize the nurse-patient assignments to see whether we can reduce that overall probability of adverse events. And the hope is that what we can do, I think I have a slide here, yeah, essentially reduce the overall risk of adverse events by reorganizing nurse-patient assignments. And we expect to find that racial minority patients will benefit more from better aligned nurse-patient assignments than non-minority patients. So just to highlight the difference here, whereas much of the research that I've been engaged in through Chopper to date has been focused on these policy interventions, like I mentioned, like you hire additional nurses or hire with a preference for BSN. This work focuses a little bit more on saying, okay, on a day-to-day basis, even as we're pursuing these higher level policy-oriented interventions, I'm curious, what can we do today to better align the nurses we have with the patients we have, so that even as we're trying to improve the overall composition of our workforce, we can still make the best use of the nurses we have today, given the patients we have, and benefit, just shave off these little margins of benefit that we can have just by pairing nurses differently within a unit or across a hospital, across units within a hospital, to gain those small benefits that I believe will really add up over time when applied consistently. So just a couple citations that I included earlier in the study, and I do want to recognize and acknowledge that the work that I've done up to this point, and even applying for that, the Hillman grant, I have to thank my colleague Colin Plover, who did his dissertation actually looking at interviewing charge nurses, exploring the factors they consider in making assignments, and really highlighted a number of the problems that are out there, and as part of the inspiration for wanting to pursue this work further. So his thanks for that research and his assistance with writing the Hillman grant. So at that point, I'd like to pause and open up for questions. We've got a good bit of time, and would be happy to hear from any and all of you. Thank you. Thanks for the applause.
Well, while folks are considering their questions, Andrew, I just wanted to thank you so much for this great presentation and welcome you to the School of Nursing. We're lucky to have you, and I'm looking forward to the spring colloquium. I think this is going to be a good list of speakers coming up, and we're excited to have you.
Oh, thanks, Amy. Yes, do come back. We've got some great speakers lined up, and it will be great to engage with them. So.
Hi, Andrew. It's Laura Fenimore, and I teach in the DNP program for Health Systems Executive Leadership, and very interested interested in getting to know you better and tapping into your wisdom and how I can share it with our students. So I look forward to more interaction with you. You know, I think you've landed on a topic that really hits to a core issue for many nurse managers, and in particular, I remember in that role, I used to spend entire weekends working on developing the schedule and just trying to meet both the nurses' preferences for their own personal time, as well as trying to balance a unit that was going through a lot of change with many new graduates, and making sure that I just had enough nurses who could actually give the chemotherapy to the patients on my oncology unit. So very interested in hearing more about this work. I couldn't agree with you more that it is very much needed. I guess one of the thoughts that I had around the whole interviewing with charge nurses and how they make assignments is the whole problem of geography and the layout of the unit, and that the best nurse to care for perhaps the sickest patient may be geographically located in a different part of the unit. And just wondering how you've incorporated that nuance into the planning and assignments of patients.
Yes, you raise a great point. And I think one way in which we've approached this is the current or the proposed design, or part of the design for this software, is that you would have a unit map and be able to visualize assignments in various ways. But one way would be actually looking at a plan view of the unit and perhaps highlighting where the distribution of this assignment across the unit. I mean, these are some of the strengths of software that aren't very complicated. I think there are some things we can do that are more complicated and more data driven and whatnot down the road, but there just seem to be so many benefits to at least so much potential in making the system, this process electronic. And one of them is better visualizing that spatial distribution of a nurse's assignment across a shift. And, you know, right now, I think the first step is not to take this out of the control of the charge nurse. They have some expertise and experience in this for sure, but it's to better equip them to realize these different parameters of the assignment and help them consider the trade-offs. So, you know, whether it's generating some sort of distance metric for different assignments to make sure that, hey, you're not spreading someone out too much, or just presenting that visually as a map. Those are all different ways to say, okay, we're not taking it out of your control, but we're giving you a better sense of how this decision impacts things like spatial distribution across the unit.
Great, thank you.
Yeah, thanks for the question. I look forward to getting to know you better.
Great.
Hi, Andrew. It's Krista and Julie. Hi, thanks for your presentation today. It was interesting to learn about your work. I was wondering about changes in patient acuity and kind of how frequently during a shift you might reassess assignments and how you take into account changes in patient acuity.
Yeah, that's a great question, and one that comes up commonly, especially when we're speaking to nurse managers. Everyone wants to know, well, how are you doing nursing? How are you doing acuity? And the answer is, we don't have kind of a special or proprietary approach to acuity. I think it's an interest of mine. It's a related interest, but it's a difficult one to solve. And there've been some attempts at it, but I wouldn't say there's really any gold standard to it. Every unit does it a little differently, and at least for phase one of this, the initial introduction, it's just, hey, let's replicate what you're already doing in an electronic form so that we can begin to study what you're doing and whether or not it works, and perhaps as a result, we can then have the data we need to make some recommendations that might be evidence-based. So to answer your question, we're doing it in no way different than they're already doing it. We're just trying to replicate current practice. And down the road, perhaps this will yield different findings, but right now that's kind of how it is. In terms of frequency of re-evaluating assignments, I think it's a great point because patients do change over the course of the day. Their workload changes. And so the broader vision for this is a little more sophisticated than I think this initial form will be. So I don't want to overstate, what it's going to be probably in the next year or two. But the potential is there if we do develop some sort of scale that can be generated from information on the patient, pulled from the electronic medical record. There's opportunities there for integration. And if we can kind of figure out what that formula is for really assessing acuity well, then it's something that can be updated as often as information is entered into the electronic medical record. So that's, and then, the charge nurse alerted accordingly. One other aspect that's related to your question that we've been thinking about is, acuity is just really one aspect of the patient. And there's also workload, which can be separate and maybe not even collinear with acuity. And then maybe something that's even a little different is just the stress level that a patient might have on a nurse. And then also, finally, acuity, workload, and stress might be very different for someone in a nursing role than they might be in a nursing aide role. And so those have to be treated very differently. And I think in most cases, if a unit is using acuity, they're not doing it separately for nurses and for nursing aides. For very understandable reasons, it just becomes unmanageable. But I think if you have a system that's doing this for you in a trustworthy and reliable way, then you can begin to get a little more complex, provided the system's doing a lot of that for you on the back end, and not adding too much work.
Thank you.
Thanks for the question.
All right, I didn't realize how un-camera ready I am, so I'm turning off my camera. Andrew, that was fantastic. Thank you so much. I have two questions if we have time, but I want to let other people ask questions if we don't. One is just building a little bit off the subtext of Dr. Fenimore's question or comment, which is just that, like, for a lot of the nurse managers that I know, it's all they can do to put a warm body in the unit, right? Like, they struggle to get enough people to show up every day, let alone thinking amongst the pool of potential nurses who is the best nurse for that day for those patients, right? So this, I guess, speaks to the practical notion of, will this software or will this approach yield much marginal gain given all the other, numerous barriers to just getting enough people to show up to care for the patients?
Yeah, you're absolutely right. So I have a number of thoughts all at once. I'll try to address them in a more organized fashion than they're occurring to me right now. But maybe by way of a few examples. So there's a staffing component is represented by a number of different processes. So one is in HR, how do we recruit and hire nurses? So who are we looking for? I think if we can figure out where our holes are in terms of, we have patients who have specific needs and preferences, and we have nurses who are already in our pool of employees who may or may not meet those needs and preferences based on what we know about our general patient population. And so you can kind of work backwards to say, okay, well, these are the holes in certifications or education or whatever it might be, various levels of experience. I mean, I don't even know exactly beyond just kind of educated guesses or hypotheses about what might be important. But we can begin to work our way backwards to say, okay, these are the nurses we need to best care for our patient population at this particular hospital. So that's one way in which that takes place. Another way is, at a more day-to-day basis, that staffing component comes in at the beginning, before assignments are even made, when the hospital evaluates its situation and says, we're understaffed on this unit, we're overstaffed on this other unit, we're going to pull a nurse from the overstaffed unit to the understaffed unit. And it's likely in a larger hospital that there are several understaffed units and perhaps several that are relatively overstaffed. And so where I'm going with this is to say, well, how do you decide beyond just basic ability to care for the patients on this other unit? How do you decide which unit to float that nurse from and to? And I think you have a couple options there. And it's not always clear because you don't have kind of that profile of the nurse in front of you, or let alone an understanding of the history of patients that that nurse may have cared for to know where to send them, where they will be, where they will see patients perhaps most similar to those on their home unit. So that's kind of an example. And then likewise, when it comes time for that nurse who arrives on a unit that is not their home unit, now this nurse manager has a nurse who they don't know at all, and they don't know what kind of patients to assign to them reasonably. Well, the idea is, if you have a program that can keep track of that patient's or that nurse's experience and history with patients, it can suggest, in theory, patients who are most similar to their experience and expertise. And I know, at least where I work, I see a lot of sickle cell patients, and sickle cell patients end up on 2 floors at the hospital primarily, if they're there for a crisis, my home floor and another unit. So if I get pulled to that other unit, it probably makes the most sense for me to take care of the sickle cell patients on that other unit, because they're most familiar to me, and not the oncology patients who are, not within my kind of wheelhouse. I don't know if that helps answer the question, but cool, thumbs up. Thanks.
I have a quick question. Given the Amazon recent experience with their attempt to use AI in their HR department, and what they learned was that their software actually systematically replicated the mistakes of the past. How do you design controls into your software that alert the nurse manager that, maybe this is not such a good idea, or maybe this nurse, because he or she is the most experienced, it's the hardest assignment every day, and eventually they leave?
Yeah, it's a great point. It's something we're definitely keeping in the back of our mind just as we take small steps. And I think that's the key. Is you don't jump into anything here. And step one is just making the current process easier. So, maybe we don't improve anything except workflow, save nurses a bit of time, and give them more information that's up to date and relevant to the process. And I think if that's all we do, in kind of the first step, we've made huge strides, and hopefully haven't resulted in any harm along the way. I don't think we would. But you're right, as we have to be really careful in terms of beginning to make recommendations. We have to make sure that these really are solid, evidence-based recommendations that we can make with good confidence. There is potential, I think, way down the road for automating certain components of this, but I think at the end of the day, nurses, just culturally speaking, I think they're going to want some level of control over this. So especially initially, it will primarily take the form of just streamlining the process, giving them more and better information, and then just evaluating every step of the way to make sure that, like, what you're describing isn't happening. So I don't have a complete answer to it, but definitely something to keep in mind. So I appreciate you bringing that up.
Thanks, Andrew.
Oh, yes.
So sort of related to the previous 2 questions, back in the day, there was this idea of primary nursing, where nurses were assigned to patients, and whenever they were available, they would care for those patients, or whenever they were staffed, in order to provide some continuity both to patients and families. And, this could, but sometimes nurses, needed to also get a, break from those relationships as well, because they could, as the has been pointed out, could be very stressful to care for high needs patients or families for a long time. So I'm curious what thoughts are on this.
Yeah, I think you're right. I love this concept of primary nursing, and I think a very closely related concept is continuity of care.
Mm-hmm.
And I think that software can really help with this. So the primary nursing model is an interesting one, and it's one that we can definitely build in if that's something that a unit wants to pursue or is pursuing already. And that's pretty, I think, pretty low-hanging fruit. But the idea of continuity of care is also of interest, because if you're able to keep track of a record, not just did this nurse have this patient last shift, but did they have them last time they were in the hospital? If they're like the sickle cell patients I described, they're back in the hospital fairly frequently in many cases, and sadly, but that is the case often. So just not just continuity of care within an admission, but across admissions. And that's where you begin to get the concept of primary nursing. Now, yeah, is there a line where, primary nursing becomes actually a burden to the nurse, and because of the type of patient, perhaps, probably someone with some chronic disease, and can be very kind of a heavy patient, so to speak. Well, yeah, that's where the ability to override these recommendations, as especially in the early stages of where we're implementing this, I think that nurse intuition needs to be an important driver of these decisions, and that the software isn't taking over, but is supporting hopefully good decision making. But hopefully also, whether a nurse gets burned out by primary nursing model, hopefully that's something we can learn about nurses, maybe even begin to predict about nurses, like what is it about the nurse, that their characteristics that might cause one nurse to get very tired and burned out by that model, whereas another nurse might prefer it just because of who they are. And I don't know what might begin to predict that. What about their personality or experience or education? I don't know.
Or the contextual factors and the support they get from their unit that enables them to, take on this role. So
right. There's all sorts of interactions there, I'm sure, that haven't even begun to unpack, but you're thinking along the same lines, where there's a world of possibilities here, and it's really, I find it exciting to begin to think about unpacking that. So
thanks
for the question. Yeah, I know we're approaching 10 o'clock. I'm happy to stay on if anyone wants to chat a bit more or whatnot, but please feel free to head out if you do need to get to your next meeting.
Okay, I had one other question. Has anybody given thought to making a financial case for returning to 8-hour shifts?
That is a great question. I don't know. I don't know of any study, but I'm trying to think. Could you explain a bit more what you're thinking there, how you would study it, and what the financial case might look like?
So at one point in time, there were 8-hour shifts. Mm-hmm. And then as 12-hour shifts became more popular, they became the norm. They also saved the institution money because there's less time spent in handoff. There's a half-hour overlap every time you hand off to the other shift. So you decrease that. Plus it gives management exposure to both shifts. You see them Whereas in, an 8-hour model, if you're the manager and you're only there for 8 hours, you never see your evening people. You might not see them very often. So, but then there's sort of, but there was a transition where now it's very unusual to find 8-hour shifts, but there's a lot of evidence that errors occur in the last 4 hours, particularly med errors occur in the last 4 hours of a shift, and other errors. And I'm just curious about what thoughts are about this. Obviously from a staffing perspective, it's really hard when you have a mix of people working 8 and 12 hours. But having 12-hour shifts almost always necessitates this sort of week of 4 where people work, 4 12-hour shifts in a week, which can be incredibly stressful. And I'm curious about what the compounded effect of those errors might be when somebody's working their 4th day.
Yeah, it's a great point. I don't know exactly. I do believe there's some research on 8 versus 12-hour shifts. I'm not 100% sure, but I think in general, nurses prefer the 12-hour shifts. I do know of at least one hospital here in Philadelphia that actually does a mix. They do what do they do? 2 12s? No, they do
2 8s and 2 12s.
2 8s and 2 12s. They add up to 40 hours. They try to
40. So
yeah, exactly. So they try to make sure that happens. I don't know. I think in general, nurses at that point are like, I'd rather just come in 3 days, do 3 12s, than have to come in 4 days and do these kind of 2 smaller shifts. But for sure, there's so many competing interests there. And one of the things that I've been paying attention to and kind of learned through the I-Corps program was really learning about hospitals and the financial incentives. And it is, I think often we begin to translate results into financial numbers, into money, whether it's lost or gained for a hospital, and really try to make that business case for investments in nursing. But not all dollars. I think hospitals don't always recognize the dollar signs that we put out, like saying, for example, this infection, results in this.
I don't know. Maybe there are nurses. Maybe nobody wants to work 8-hour shifts. Maybe nobody wants to work a mix of 8 and 12. But I also know that a large generation of nurses has never done either, and maybe can't say. And since the workforce has aged, the average age of nurses is what now? Over 40. The last time I looked, it was 42. What's the impact of being someone who's not 28 years old on working a 12-hour shift, when oftentimes the work is not just cognitive, it's physical and cognitive. So I have these questions also about the concepts of self-scheduling. And
yeah, I see.
And that as well, I think, is a topic that has, you hear self-scheduling put out as like it's a plus, but it always for most people that I talk to now, it turns out to be a horrible compromise for everyone. Someone who worked at a time when, there wasn't self-scheduling, but you did a 2-week rotation. That was the same from now until, next year. Unless you made any specific requests or days off, I'm just really curious about what we automatically assume, well, this is the best, this is what everybody wants. I just hear incredible amount new nurses saying that they swing back and forth within within a 2-week period, which is, to me, seems like a really negative.
Yeah,
especially for errors and for satisfaction. But they say they have to do it because it's how they manage to keep self-scheduling.
Yeah, there's so much to learn in this area, and you know, you're raising questions which are, gosh, I would love to begin to look into those a bit more, and I'm really hoping I'm hoping, as it works out, is, you know, pursuing this innovation, developing this software platform. One of the big motivations is, well, helping nurses and patients. But from like a research standpoint, I just haven't found a place where this data set is available.
Mm-hmm.
And so, unless you collect it in a very kind of laborious, expensive way. And so I am really hoping that this will be the foundation for a program of research that can begin to answer not just the questions I've outlined, but those that you've begun to, you know, expand on, and hopefully it can be of real assistance to other researchers at Pitt, and provide lots of ground for collaboration. So,
well, thank you for entertaining my questions, and
my pleasure.
Thank you for doing the research, because I think it's fascinating, and I think it has an incredible impact on patient care and health care. And it's just not even recognized how the effect of these things that we just take for granted, that people don't even think about. So thank you.
Oh, thank you. I appreciate your interest, and thanks for asking the questions and showing up today. That's awesome. All right. All the best to you. Thank you.
And once again, thank you, Andrew, unless there were any other questions for the folks hanging on. Looking forward to our next Spring Colloquium presenter. So thank you.